Dr. Swastik will join.
Good evening, sir. Dr. Rahul, sir, and Dr. Atisha and Dr. Achin, sir, will be answering today. Kindly make everyone co-host.
But first, you are going to display 6 slides. So that will be about, we'll give them 14 to 15 minutes. And after that, we will start discussion. If Dr. Dastur joins earlier, first we will finish with urodynamic slides and later on whatever is left, last time. Okay, Swastik, you can tell them when you're starting and give 2 minutes to.
So, shall we start, sir?
Yeah, please.
Yes, sir.
Already
Okay.
start.
This is the first slide. Your time starts now. One minute over. Fifteen seconds left. Time up. 1 minute left. Fifteen seconds left. Next case. One minute left. Ten seconds left. Time up. Next case coming up. Sorry. 1 minute left. Fifteen seconds. Time up. One minute left. I have zoomed the graph. Time up. Twenty seconds left. Time up. Next case. 1 minute left. Fifteen seconds. Time up.
So Swastik, today's all the six are over.
7 were there, sir.
All six are over.
Yes, sir. All over, sir. 7.
Okay. So just I am Dr. Bakhtawar Dastur is joining. So we will start.
Sir, should we go ahead with last previous force?
No, madam is already joining. Just 1 minute.
Okay, sir.
Hello.
Yeah, yes, madam is okay.
Yeah, but I can't see.
Yeah, good evening. Good
okay.
evening, madam. Dr. Bakhtawar
Good
Dastur is
evening.
a pioneer in urodynamics. She is one of the first to start probably in India. So we are, thankful for her to be, joining us.
I can.
Madam, you can hear us?
Excellent. Yes, and can see the graph too. Thank you.
Okay,
Thank you.
Okay, so we'll start with the first one. Pankaj bhai, you are there?
Yes, I'm there.
Yeah. Okay. Who is answering first? Who are answering?
Sir, I am
Sir,
answering. One Dr. Rahul is answering, and Dr.
Atisha.
Atisha is
Atish. Sir, I am Dr. Rahul. I will answer these questions.
Okay, you start.
This graph of Euroflow showing the poor flow with hypoactive detrusor where Qmax is 12.3 and voided volume is less. So this graph is interrupted because of hypoactive detrusor as patient had a history of lumbosacral meningomyelocele surgery at age of 4 years. And to support this, we have to do cystometry uh, uh, for a detailed evaluation of this patient of for the functioning of the bladder and important parameters for this patient's treatment is bladder pressure as well as action of detrusors which uh, needs to be treated for the functioning.
Okay. Fine. So why this type of interrupted graph, even if it is a hypocontractile detrusor, if it is there, why such a interrupted prolonged interruption is there?
Sir, maybe there may be some intrinsic sphincter deficiency also associated with this kind of the patients. So that's why the interrupted graph is there.
So if it is a hypocontractile detrusor or a contractile detrusor, how the person will void?
Sir, she must be on continuous intermittent catheterization or catheter should be placed
No, I am
for
asking
the
you
drainage.
during this graph when she is voiding,
Yes, sir.
is she using any other effort?
Sir, abdominal straining must be there to avoid the urine.
Madam, will you like to ask him and clarify anything on this? Dr. Dastur,
Can you hear me? Can you hear me?
yes, we can hear you.
Yes, ma'am. Yes, ma'am.
Huh. The interrupted flow, the causes are either the patient is straining and passing urine, or there may be detrusor sphincter dyssynergia, involuntary contractions which are ill-sustained. They come and go, and during relation phase, they leak out urine. Okay? So
Yes,
it's not just hypercontractility. It can be overactive hyperreflexic bladder along with this synergia. Okay? Did
Yes,
you get
ma'am.
it? Hello?
Yes, ma'am. Yes, ma'am.
Huh? So these are the
Yes, ma'am,
causes.
we are getting it.
Huh. The detrusor contractions are ill-sustained. They rise, they come down to baseline. They rise, they come down. So the flow can be again interrupted, or the patient has no detrusor contraction and the patient is straining only. Okay?
Yes. Yes, ma'am.
So what I would
So
suggest
you
is from
have
after
to
hearing what madam has said, I would suggest that you should say the probable causes are either hypocontractile or overactivity.
Yes.
You must not just look at a
correct.
Euroflow
With
and
this synergia,
yeah, you must not just
with
look at a
this
Euro.
synergia.
Correct. So you must not just look at the
Huh.
Euroflow and say about
So
detrusor
further
because
test is required.
further investigation. Correct, correct. That's what I'm saying. Without a
Yes.
urodynamic, you cannot comment actually about the detrusor. So you should say the probable
Correct.
causes could be these because given the
Correct.
history, these could be the probable causes. Either it could be overactivity or hypocontractile with straining.
See the graphs. Okay.
Sir, other investigation beside Euroflow is to ultrasonography of abdomen and pelvis. Ultrasonography of kidney, ureter, bladder with cystometries.
Correct. So now see, you're in a urology exam. So when you do a cystometry, you would like to know na, that the urine is not infected. So you
Yes,
you
sir.
can say yeah,
Urine.
basic investigations, beta, you will never go wrong. If you say urine routine, creatinine, and
Urine
then
routine
I will do
microscopy.
and then I will do further investigation. You will never be wrong. So these three
Yes.
things in exam, if you say urine routine, creatinine, and ultrasound, nobody is going to penalize you. But they will
Yes.
understand that you are thinking because now you're going to do an invasive test, right?
Yes, sir.
Good.
Correct. Excellent.
What type of cystometry you like to do?
Now, which pair?
Hello.
Yes, sir.
If the facilities are available, what extra thing you may do?
Sir, I would like to do video cystometry to see the bladder neck functioning also.
Very good. Very good.
Right. And which parameter is important for the treatment?
Sir, parameters, low bladder pressure must be there, and detrusor activity should be there. And for the treatment, there should be low pressure which do not transmit to the upper tract, and upper tract should be saved.
So, beta, you have to say that the most important parameter is that you do not want a high pressure bladder.
Yes,
Okay,
sir.
you have to explain that
Yes.
properly. Yeah, it should be a clear message that you do not want a high pressure bladder because conservation of upper tracts is the most important in this child. So you have
Yes.
said it, but just put it in properly. Message clear, absolute clear message.
Yes.
Besides the pressure, what else is more important? Besides the detrusor pressure,
Yes, sir.
can you
Yes,
hear?
ma'am. Yes, ma'am. Yes, ma'am.
Huh. See,
uh,
most important is the post-void residue.
residue. Yes, ma'am.
Whether the bladder is acontractile, whether the bladder is overactive, your treatment will be based on post-void residue and the leakage component. Okay? So don't
Yes,
just
ma'am.
go by the figures of detrusor pressures.
Yes, ma'am.
Of course, you have to keep the pressures low, but ultimately you will decide if the post-void residue is there or not. Would you allow the patient to pass urine involuntarily or voluntarily? Okay.
Yes, ma'am.
Then if there is post-void residue, you have to institute either it is acontractile or hyperreflexic with dyssynergia. You have to institute intermittent catheterization
Catheterization.
along with that.
Patient
Okay.
should be put on
So
CIC.
post-void residue is the most important factor. Okay.
Yes, ma'am.
So your principles of treatment will be to keep it a low pressure bladder, prevent breakthrough infections by preventing post-void residue, and make sure that there is no constant.
NMP.
Yeah.
Yes,
Hmm.
ma'am.
So
Okay.
normally in neurogenic bladder, what are the, what is the treatment you normally follow?
Sir, there should be a complete complete drainage of the urine. So we will put the patient on regular CIC 4 to 6 times a day, depending upon the what amount of the PVR, what amount of the urine coming after doing CIC. Then, sir, we can put the patient on alpha blocker, and if patient is not willing for continuous intermittent catheterization, then we can put a catheter, uh, Foley's catheterization. And if
One is the draining, second is
then, sir, if blood detrusor is overactive, then antimuscarinic should be given to stabilize the overactivity, and alpha blocker, sir.
third.
If there is incontinence, hello.
Yes,
Please
yes, ma'am.
answer. Have you understood the question?
Yes, sir. If patient is incontinent, then sir, patient can be put on catheterization, or patient.
If there is total incontinence, sphincter is denervated, what will you do?
Then, ma'am, sling operations.
Anything else? Sling is in a child, 10-year-old. Will it hold for how many years? The child is going to grow. It's only 10 years. Gaurang, help him.
You are doing well, don't worry. Huh?
Yeah, madam, you can explain them.
Is there any scope of diversion if the person is totally incontinent and if the person is paralyzed, non-ambulatory? Everything depends on that too. Once it's a neurogenic bladder, you have to see all the aspects.
Yes, ma'am.
Ultimately, the aim is to save the kidney. Okay.
So you understood what madam is trying to tell
Yes.
you. So first is
Yes.
what you said is right. that it is antimuscarinic, you will do CIC, you will give antibiotics to prevent the infection. Okay. Along with that,
Yes.
if there is a, you have to avoid constipation, maybe alpha blocker. But if the patient is totally incontinent,
Then diversion.
then you have to do some sort of diversion.
Metronov.
Okay. Because even if you do, even if the patient is incontinent, and if you do any other way, like you do suprapubic or you put the catheter, whatever it is, there are chances that still from the side, the patient will pass urine, and you cannot keep it permanently like that. So that is one of the good option.
Yes.
Gaurang, I would like to add one point.
Yeah.
What did the PG students say about the flow rates are? Doctor, flow rates are poor, normal, what have you said? The child has voided 100 ml.
100 ml for 100 ml volume, ma'am, flow rate is good, 12.3 millisecond per second.
See, you have to say that volume, avoided volume. What will be the normal capacity of 10-year-old female?
Around 200 ml.
It is approximately 30 ml per year.
30 ml per year.
Normal. Coughs formula, everything is okay. But if you have to decide very fast, it is just add 30 to multiply 30 and number of years till 14 years. Okay. So this will be approximately anything between 280 to 330 ml.
300
Right.
ml.
So now
Yes,
she
sir.
has passed only 100 ml. Do you think it
100
is
ml.
okay?
No, it's low volume. Bladder capacity is small as compared to her age.
Yes.
And
So minimum is
for Euroflow to interpret, minimum 150 ml urine volume should be ordered by the patient, so we can comment on the authenticity of Euroflow.
So, madam, can you just explain them that how to read uroflowmetry and how to answer in exam? Dastur, madam. Hello.
मैडम अनम्यूट कर दो.
Can you hear me?
Yes.
Can you hear me?
Now we can hear you.
Huh.
Can you just explain them how
The
to read
peak flow. The height of the curve gives the maximum flow rate, which is also known as Q max. Okay. The horizontal line from beginning till the end of the flow gives the voiding time, and there is flow time. Voiding time, volume voided divided by voiding time gives you the average flow rate. But this varies with the flow pattern. If it is interrupted, the voiding time and the flow time is different. If the pattern is interrupted, you understand? And how we calculate in children, it is square root of the volume voided. Now this child has already voided 100 ml. Square root should be 10. She has, the peak flow is 12 point something. So that way, okay.
Okay. Okay, madam. When can we go for a second one?
Sorry, Gaurang. Yeah, please.
First take second. Who is going to answer this now?
Sir, I am Dr. Atish, sir.
Yeah. So please. Read the question.
Yes, sir.
Swastik, yeah.
72-year male with complaints of diminished force of stream and striding at micturition, sir. This is a Euroflowmeter curve.
Yeah, so you first read the uroflowmetry properly,
Yes,
all the as madam has explained you, okay, and then comment
yes,
on that, okay.
yes. 72-year male, he has avoided a volume of 120 ml with a flow time of 22 seconds. There is a bit hesitancy in his flow, delayed flow, with a Qmax of 10 ml per second, which is with a late Qmax in the second half of his stream, and it's a poor flow for his age, with a Q average of 5.4 ml per second. So this
So flow
Euroflowmetric
rates are
flow rate, maximum flow rate is 10 ml per second, ma'am.
and the voided volume is 120.
120 ml.
And the age is 72.
72. Considering it to be an adequate voided volume, he's having a poor flows with a poor Qmax in the second half of his stream, with a bit of hesitancy in his flow to initiate the micturition. So probably he's having a bladder outlet obstruction with poor flows, or a detrus or underactivity, which both can be considered, because uroflowmetry, we can't decide the exact cause, whether it's obstruction or underactivity.
Madam, you can just answer them or you can correct them, huh?
See, according to the age and the volume voided, the flow rates can be considered borderline between 10 and 12. Okay. And other thing is, see the time to reach the peak flow. It is known as TQ max. It is delayed. It is delayed. In a normal curve,
Yes.
it comes in initial 1/3 of the voiding time. Whereas in this graph, TQ max is delayed. Have you noticed that maximum
Yes, ma'am.
flow?
Yes, ma'am.
Now, what are the causes of this delayed TQ max? Is either underactive detrusor or
Yes.
bladder neck obstruction.
Yes.
So that you have to keep in mind.
Yes.
Okay, these are the two causes. Okay,
Yes.
we can go to the next one. Graph, guys. Gaurang, next.
Yes, sir. Please do.
The upper graph is a uroflowmetric curve of a 65-year-old male who complains of slow stream. He's having a hesitancy of around 1 minute, with a box type of curve with a plateau flow rate, Qmax of only 7.2 ml. He has voided the adequate volume of 171 ml, and the average flow of 4.6 ml per second. Maybe is having a bladder outlet obstruction in the form of urethral stricture, since it is a box type of curve with a plateau curve. And the lower uroflowmetry graph is of a 57-year-old female who has a slow stream with an history of OAU, repeated
Are you
urethral
there?
dilatation. Hello?
Video gets stopped.
Yeah, go ahead.
Yes, sir. And there's also a history of Otis urethrotomy. She had a bladder neck incision in the past. In this uroflowmetry curve, she is having an hesitancy for 1.5 minutes, with the interrupted flow with a Qmax of only 7.2 ml per second, which is very unusual in a female, with a voided volume of 171 ml. Maybe she's having a recurrent urethral stricture failure surgery, previous surgeries. That can be my interpretation of this uroflowmetric curve in a female 57-year female.
Madam, you can answer. Dr. Dastur. Hello.
Also,
Yeah, Gite sir, you can also just explain him.
Yes, sir. Uh, why not it is only a benign prostatic enlargement or dysfunctional widening in a upper curve. It is a 65-year-old male. The common disease at that age is a benign prostatic enlargement in spite of a stricture urethra. And whenever there is a median lobe, that median lobe act like a ball valve mechanism, and the flow is very slow when the patient try to pass urine using the abdominal muscle. And in same type of the pattern of uroflowmetric curve will be seen in such type of patients. So you cannot differentiate at this age without having any history or clinical history with this curve only. It is a stricture or BPH.
okay, can be considered.
Yeah, so in both the cases, what you are saying is right. And in above first graph, yes, Dr. Gite has suggested, even if there is a small prostate like fibrotic prostate, you may get such a graph. Or there may be coexistence of, some sort of prostatic enlargement, that obstruction along with the urethral obstruction.
And in case of lower curve, the patient has already history of multiple optical orthotomies and dilatations, and such patient usually needs to the bladder neck contractions.
Yes.
In spite of a stricture urethra, whenever you take the incision at the bladder neck, that when that will get stenosed or contracted, then it will present like this. Patient will not able to pass a single drop of urine sometimes, or very few drops of urine, and such picture will be there. So in spite of telling in exam it is a stricture urethra in female, it should be told as considering the history, it will be a bladder neck stenosis. Because that patient has a BNI.
DNA, yes.
So, Dr. Dastur, you want to comment anything? I hope she's not. She has again muted.
Can you hear? No.
Yes,
Yeah.
we can hear him.
Yes, madam.
No.
Madam, please unmute कर दो, madam.
You are.
Can you hear now?
Yes, we can hear you. Yeah, we can hear you. Madam, you are muting yourself, so you have to unmute.
It is unmuted.
Yeah. Now we can hear you. We can hear you.
Okay. So initially the peak is reached. It is lower than the normal in obstructed prostatic enlargements. Whereas here you see the peak is reached and it is steady all along till the end of the flow. See in both the graphs. So this is considered as a box type graph where there is fibrosis or rigidity of the urethra. What level it is immaterial, but it is, can you appreciate?
Yes.
The flow rates remaining constant till the end of the flow, and then it drops suddenly. Okay?
Yes.
This is box type of curve, suggestive of stricture. Okay.
Yes.
And as you can see, the peak flow is low, 7.2 in the first case. No, first, sorry, is 5.6 and here it is 7.2.
7.2.
All right.
Yes.
Any doubts?
Ma'am, in females, uroflowmetry
It's
interferes
suggestive of
pressure.
whatever the pattern, it is
Yes.
suggestive of.
Yes.
After doing complete urodynamic study or pressure flow study, that will be conclusive for outlet obstruction. Okay? But uroflows will suggest. That's all. Abnormal or normal flow. Okay?
Yes.
Considered as box, where the flow is maintained at a continuous speed, same rate, and then suddenly drops when it stops. Okay? Shall we go to the next, or you want to discuss this
No,
further?
Next
Kasi-
question will be answered by Dr. Rahul, sir.
The spelling.
What's the questions?
Who is answering?
Sir,
Who's
spot diagnosis,
answering?
sir.
Yeah, Rahul,
Dr. Rahul.
answer.
Yeah. What is it? What do you see over here? Flow rates are?
Rahul,
High flow rate.
I think he has to unmute.
Cannot hear.
Rahul, you have to unmute yourself.
Fine, sir.
Rahul, you have to unmute yourself.
Yes, sir.
Okay.
I could hear him, yes, sir.
उसके साथ
Madam, you can ask him again, please.
The first curve, Euroflow curve, the flow rates are normal.
Flow rate normal.
What else
Yes.
do you observe?
Ma'am, after a peak, it has a plateau phase, and there is a
Do you see the first spike before the Euroflow starts?
yes, ma'am.
Do you see?
First,
I don't have a
yes, ma'am.
anything. First, there is a spike, and then the Euroflow starts.
Euroflow start.
This
Yes,
is the cough stress test. When the patient coughs, there is leakage. We tell the patient, don't pass urine. We make them cough and see if there is any leakage. Now, this patient has demonstrated leakage. So what is your diagnosis?
Ma'am, stress urinary incontinence.
Correct. Stress urinary incontinence. Now, the second graph, the blue line wala, you
Yes,
see very tiny spike you see. This is the urethral pressure profilometry, which shows pressures less than 20. So this means that stress incontinence is secondary to incompetent sphincter. Okay?
Yes, ma'am. It
All
is
right.
kind of the
Understood?
mixed urinary incontinence.
No, mixed is different. Mixed incontinence means there is urge as well as stress. Urge due to involuntary overactive bladder, and stress is due to raised abdominal pressure without detrusor contraction. Okay? So you cannot call it mixed type. Okay? Incontinence can be urge incontinence, stress incontinence, mixed type of incontinence, or total. Remember
Yes.
that. Okay.
Yes, ma'am.
Or then congenital defects like ectopic ureters. Okay. Or
Yes, ma'am.
iatrogenic. All right.
Yes, ma'am. Yes, ma'am.
Shall Gautam next. So yeah. Anything else you want to ask? Okay. Now
Dr.
this
Atisha,
is
sir, please.
In earlier case, Dr. Gite, Dr.
okay.
Maheshwar, you want to ask anything related to that?
No, no, sir. Thank you, sir.
Okay. Who is answering this?
Sir, Dr. Atisha, sir.
Yes. So, there is a 57-year-old male patient who had acute urinary retention 1 month back. He had a history of slow stream and straining with occasional urge incontinence for 1 to 2 months. This urodynamic study in his storage phase, there is a delayed sensation with the maximum systometric capacity of 254. Initially, the calibration looks okay with cuff. There is no urinary leak. And at the late filling phase, there is detrusor pressures are increased, and with the concomitant intravesical pressure increase, but abdominal pressure remaining stable. After the initiation of micturition, patient is having poor flows with a good detrusor contraction and vesical contraction. Uh, uh, it can be the patient might be having a dysfunctional voiding. We need to see his electromyography, sir. It can be a detrusor expansion dysynergy also because very high pressure voids. Even prior to initiation of this micturition, the pressures are high. So I want to look for his sphincter electromyography.
No.
No.
Before that, have you done regional
Yeah,
neurological
yeah,
examination? This
yeah.
patient had normal regional neurological examination.
Examination.
What all you include in regional neurological examination?
Yes, ma'am. I'd like to include examine his spine, any dimples, any
What are the parameters? What do you look for? How do
I'd
you
look,
do it? Regional.
yes, focus neurological examination for a sensory examination, motor examination, and reflex assessment.
And how do you do
And
it? Which
yes,
segments you are examining?
lumbosacral.
S2 to S4.
S2 to S2.
Sensation you see, perianal.
Perianal sensation.
You do per rectal examination. Look for the anal tone, whether it is normal, whether it is weak, or whether it is just diminished, slightly low. Then you look for voluntary contraction of the sphincter. Ask the patient to hold, squeeze, whether the patient is able to do or not, absent or present. And lastly, bulbocavernosus reflex, which is the knee jerk of the urologist. Remember?
Yes.
Huh? Whether it is. Now, his neurological examination was totally normal. You have missed out on one point. Maybe you cannot see properly. Before starting the voiding phase, can you see the detrusor rise?
Yes, ma'am.
Without giving command to void.
Yes.
So what does that mean? What does that mean?
It's detrusor
You see the
overactivity.
line,
Yes.
filling phase is on the left and the voiding phase is on the right.
Late filling phase, he has a detrusor overactivity, abnormally overactive detrusor.
Correct. That is involuntary contraction. And there was leakage too. See in the results, it is already marked below. Leak pressure. At what volume and at what pressure? That pressure was high. Now, can you tell me what was the opening pressure and what was the pressure at maximum flow? See properly the results. In fact, I have marked also. You should know how to read.
Yes.
That is important. That's why I'm asking you. You can't just see the graph. Huh? देखा कि नहीं?
No, I'm not able to see it.
Opening pressure is 95. After dot, P det open. In results, down. Voiding phase. Voiding phase result. Can you read? I cannot mark it. I can take it up also.
Yes, ma'am.
Filling phase results you have read.
Voiding phase.
Then below, go below.
Yeah. P date open
Below.
95.
Below, voiding phase results. Opening. And P that Qmax is?
89 centimeters.
Very nice. And the flow rates are? Voided volume is first. 127.
Voided volume is 127.
Down, go down. In voiding phase only, everything is given.
Yes, ma'am. Voided volume
You
is
don't have to
only
depend on my report only. You have to see the results and you'll know the diagnosis too. Okay? Voided volume is 127.
7.
Maximum flow rate is 3.8, which is very poor. And out of 251, the patient has voided 127. Okay? So residue will be roughly 127 again. So what is the diagnosis? Or will you say decompensated obstruction with overactive detrusor? Okay? Understood? Decompensated because there is residue. Residual urine. Pressures are high. Flow is low. Flow rates are low. Okay? This is a indicator of outlet obstruction. Anything else you want me to
can't hear you.
Okay. Now this is the urethral pressure curve. This is not very clear because the infusion through the
Yeah. Yes, madam, go ahead.
No, anything else you would like to ask?
No, I think that's over. So we go ahead. Swastik, next case.
Yeah.
Dr. Rahul, the answers.
Consider graph. What is the next graph?
This has two Euroflowmetry graphs. First is before the study, then after catheterization, patient catheterized, and then the second study, post-test study.
Sorry, okay.
Who is answering? Rahul is answering?
Yes, sir.
Yeah. So now,
In
read this study and
first,
answer.
sir, first Euroflow suggestive of obstructive pattern in which uh, there is a intermittent which shows intermittent flow along with increased volume, and in cystometry, which is in filling phase, suggestive of high pressure with low compliance, and on in which has a first desire at uh, 208 ml, and in voiding phase, it shows both abdominal staining as well as high pressure in the detrusor, as well as PV cycle is high, suggestive of bladder outlet obstruction, and high capacity bladder.
Large.
Madam, your comment, please. Madam, you have to unmute yourself. Rakesh, make her co-host again.
This patient has developed detrusor contraction with straining too. Although it is a detrusor contraction, high pressure, low flow rates, and the detrusor is stable, whereas the previous patient had overactive detrusor. So diagnosis is outlet obstruction with normal stable bladder. Okay?
Yes. Yes, ma'am.
Okay. And compliance is not low, huh? You answered wrong. Capacity is 404, end filling pressure is 24. Compliance is normal.
Yes.
How do you calculate compliance?
Change in the pressure with respect to change in
Ah.
volume.
Change in volume over the pressure.
Volume,
It is
sir,
that.
over the
You
pressure.
said the other way.
Correct.
Volume over the pressure. Huh? And
Yes,
what
sir.
is the normal
Yes, ma'am.
range? Normal range is around 20. 20 to 30. Okay.
Yes, ma'am.
Here the end filling pressure is 24 and the capacity is 404. So roughly it comes to 20. Okay.
Yes, ma'am.
So compliance is not low. Remember. And of course, the proprioception is delayed at 200 and above 200. Okay. So these things you have to look for. Okay. Okay, Gaurang, anything else?
Yeah, but my question to him is, I want to ask him that there are two graphs, correct? So the first graph is showing obstructed and second is showing little improved in uroflowmetry. Why it is like that?
What are the rates in the first one? Nearly the same. What are the rates in the first graph? voided volume 160.
voided volume.
No. Huh. It's the same,
220.
Gaurang, nearly. 217 ml voided. 5.1 was the peak. Now see in the pressure flow study down results. Go down. 240 ml and the peak flow is 6. There's hardly any difference.
No,
5
the
point
last graph.
something to 6.
See the last graph, madam.
Okay, I can't see. This was nice. Correct. What is this indicative? The flow became nearly normal, 14.6. Oh yeah, I missed the point. I didn't see that graph. Yeah.
Maybe the
So what do you think? In what case the flow will improve like this? Will it improve
because we catheterize the patient to instill the saline that may have improved the flow rate
due to dilatation effect?
dilatation.
But then will the prostate improve like this? In what conditions dilatations help? Does dilatation help in prostate?
Bladder neck stenosis or stricturous disease.
Yeah,
it may
common
help.
stricture. Bladder neck,
Yes.
even if you dilate, initially in 24 hours, you'll see good flow and immediately it will go down. Immediately. They don't improve. Prostate, they will not improve with dilatation, whereas stricture will improve. So this point I wanted to show you. You see, initially the flows was very poor and the patient said he had never voided like this for last 1 year. He was happy. It was just the dilatation effect from feeding tubes, not even metal dilator or Foley catheter. See the difference, it must be a soft stricture and he responded so well. Oh, yes. Sorry, Gaurang, I missed out on this graph.
Yeah, no.
I wanted to show them and...
Yeah, we knew it. That is what I
Right?
asked you.
Yeah. And even the post-void residue has gone down.
Yes.
From initial. So you can get all this indication if you correlate all the findings. Yeah?
Yes, ma'am.
Okay.
Fine. Yeah. Swastik, the next one.
Sir, Dr. Achin sir will answer.
Okay. Madam, you can ask Achin all the questions. Huh?
તો થઈ ગયું નહીં? No, this is another one. Okay.
This is new one, ma'am. So, ma'am, this is a graph of urodynamic graph of a 10-year-old female with known case of spinal dysrhythmia. So, in this graph, we can clearly see detrusor overactivity, which is phasic in nature, and and there is very high intravesical pressure due to this detrusor overactivity, which is actually coinciding. And there is leakage also corresponding. So it's incontinence.
Yeah.
This is neurogenic detrusor overactivity with incontinence.
Yeah. What else?
And there is no.
Is this normal for a female? Is the pressure normal for a female and that to a child?
This is very high pressure voiding also. And EMG is normal, sir. Ma'am, EMG is normal. So the detrusor external sphincter dysenergia is ruled out.
Correct. What else? Post-void residue. I've written on the top. See.
Post-void residue.
PVR.
Nil. Yes, ma'am. At present, there is no post-void residue.
See the pressures. I've marked out something else also. Maximum pressure. For female child, is this normal? High pressure?
Actually, it is normal for any child. It's 162. So it's very high. It should be ideally less than 40 to preserve the upper tract.
Exactly. So this is what happens with overactivity. They may have bedwetting also plain without neurogenic bladder or overactive idiopathic overactivity of the bladder. Over a period of time, the bladder wall hypertrophies and the bladder neck obstruction sets in these cases. And here you can demonstrate, you can see such high pressure. Okay?
Yes, ma'am.
Although the sphincter is poor, external sphincter. Okay?
Yeah.
Because of the neurogenic element. And because of this high pressure happen over a period of years. Besides final dystrophism, the child has diastematomyelin and solitary left kidney, right non-functioning ectopic kidney. Okay?
Yes, ma'am.
So you have to be very careful. There are high pressure systems. Want to ask anything else?
Ma'am, can it be a smooth
Rahul?
sphincter dyssynergia, ma'am?
No, Achut. Pardon?
Hello, ma'am.
Pardon?
Ma'am,
Yes.
can it be a smooth sphincter dyssynergia because EMG activity is normal during voiding phase?
That
Can our bladder
bladder
neck
neck.
or smooth sphincter?
Correct. Correct. It doesn't. You call it dyssynergia or you call it obstruction. It's the same
Yes.
thing. But luckily,
Okay.
the child is able to empty the bladder. Huh?
Yes.
So we have to just lower the bladder pressures and increase the capacity if required. Because see, initial involuntary contraction happen very fast, within few ml, maybe 30, 40. Okay. Where did it go again? Okay.
Ma'am,
It's not
two questions, ma'am.
Pardon?
I want to ask two questions.
Yeah, go ahead, ask her.
Ma'am, there is intermittent increase in the abdominal pressure. So is this because this is a child?
No. Where did you see? There's hardly any increase. Where is it? During the detrusor contraction, where is the increased pressure?
Abdominal pressure, ma'am.
That is the red line.
So it is.
And what the spikes in between is we have to reconfirm that the transmission of the pressure is equal. So we make the patient cough at periodic time. But during voiding, where during involuntary contraction, there is nothing. In fact, you see the pressure drop. The red line, you see the waves, small waves are there.
Yes.
But see, during detrusor contraction, see the red line. It's not increasing. See, the previous graph showed red line because of straining. The pressure rise in abdominal.
What I wanted to ask is pre-abdomen is like we have commanded the patient to spontaneously voluntarily increase the abdominal pressure.
No, we have not. Why should we? These are all involuntary detrusor contractions. These happens when we ask the patient to voluntarily strain, do Credit maneuver, to pass urine. That is when the bladder is acontractile and sphincter is weak. But here there is no point of telling the patient you strain when the bladder detrusor is working. It's overactive. Why should the patient strain?
Yeah, that's what I'm asking. Ideally, it should be a straight line, pre-abdomen.
No, Baba. These are just rectal contractions or something you're seeing little, or the child is crying, or there may be rectal contractions. Then you see small, but these are not straining. Abdominal straining is not there in this case.
Okay, ma'am. Okay.
Straining is not like waves. It comes as a spike and comes down, spike and comes down. Lot of irregularity. You can't make up. See, the height of the detrusor pressure is the green line, and the total vesical pressure is the blue line. Red is P abdomen, middle line, middle channel. Vesical minus abdomen will give detrusor.
Yes.
There's hardly any strain. Go back to the previous graph and you'll see the straining. Gaurang, can you show back the previous one?
Yes, ma'am, I'll tell.
Bladder
Yeah,
outlet.
Swastik will do it. Swastik, just show the earlier one.
Not this. Not, yeah. This one. Enlarge and see. Now you see here, abdominal pressure, red line. How much zigzag it has gone because he was straining. See, even before he started voiding, he was straining.
Yeah, he
Can
was
you
talking.
appreciate
Yes,
Ram, Arjun?
yes, yes,
Can you appreciate this? This
yes.
is straight pattern. Whereas, did you see this in the other graph, last patient baby? No,
Okay.
the contraction was just contraction, high pressure. And
Yes,
that red line was flat at the
yes,
constant pressure. आ जाना lab में सिखा दूंगी.
yes, yes.
Okay. All right. Arjun, share. Gaurang, any more?
Swastik, anything left now?
No, no, sir. No urodynamics or urethrometry left, sir. Finished, sir.
Okay. Okay,
Thank
then
you.
last. Thank you, madam. Thank you very much.
Thank you,
We
Gaurang.
will request you to take one class on
Thank you.
urodynamic study.
Sure, anytime.
Yeah.
Okay.
Okay.
Thank
Okay.
you. Good night.
Thank you, ma'am. Good night. Okay.
Bye.
Dr. Gite, Maheshwari ji, and Hiren.
Yes, sir.
Yeah. So we start the last 4 slides. Last year times OSCE's 4 slides are left. So we'll just discuss that.
Question coming, sir.
Who is answering?
So can we ask everyone to answer, sir? Let's see.
Whoever wants to
From
answer.
last time only Achin sir is left, sir. Otherwise, we can ask.
Anyone else wants to
I can
answer
request
from the
Dr.
group?
Rahul sir and Dr. Atish to come forward and take the questions.
Okay. So identify the instrument. Rahul?
Dr. Rahul sir,
Yes, sir.
can you take the question, sir?
Sir, this is this instrument is a
Very
sachet
simple question.
urethrotom, sir.
Why you are saying urethrotom?
So, sir, it's a VIU sheath.
Pardon? Just enlarge it on your screen and see.
Sir, it's a passive, active VIU sheath, which consists of which is a 22 French, which is having handle as well as a obturator.
What is it, beta? It is just a working element.
Working element for VIU.
There is nothing else along with this. It is only a working element.
Yes, sir.
So what type of working element it is?
It is active working element, sir. It's a active type of working element which is used for the in visual internal urethrotomy, as well as and it is also
Achin, can you answer it?
So this is the working element, sir. It is a active, also known as a bum rocker working element, and various uses are VIU, TURP, bladder neck incision, TURBT, ureterocele excision, and various other types of our instrument are now it can be classified into two broad types. It could be active, passive, finger working or thumb working, or bum rocker or Nesbit type, and depending on whether it's single stem or double stem, and depending upon the size of the sheath we are using, it could be 22 French, 26 French. And the last question, complications during these instruments used, there is current scattering, and due to current scattering, it could be lead to stricture.
If you are doing VIU, what complication?
Bleeding can occur, sir, if we cut deep, we can enter the cork cavernous.
Extravasation?
Extravasation of the fluid can also occur.
Then during TRP?
TRP also, sir, it could be bleeding and
Eliminate now all these complications. When you are doing TRP, what can happen? If you are doing bladder tumor, what can happen? If you are doing urethrocoele, what will happen?
if a bladder tumor, we can perforate the bladder if we go deep, and there could be an obturator jack if we are working on the anterior posterior lateral wall, and especially in urethrocoele, and bladder neck contracture can occur if we use so much fulguration at the bladder neck at the time of BNI.
Dr. Gite? Gite sir, you can just ask them and correct them.
Which telescope will you use with this working element?
Telescope are normal telescope we use 30 degrees.
0 degree telescope.
If we are doing VIU, then 0 degree, and if other like the proximal OTs, we use 30 degree one.
What are the various types of blades available for sachets urethrotom?
Uh,
Half moon blade, straight blades.
And are there any specific indications for those blades? Are you there, or what's happening?
You people know answer, or you, if you don't know answer, just say we don't know, na? So we can go
No,
ahead.
sir.
So if you're using a VIU knife, which is the cutting edge of that knife? Where exactly is the cutting edge of the knife?
low clock.
And
It's
you see
straight knife.
cutting edge on the top at 12 o'clock, you can call it 12 o'clock. Or even the front edge is a cutting edge.
It's a leading edge is the cutting. Yes.
Yes, so leading edge is also the cutting edge. And the hook knife is used to be used for endopalatomy. Okay.
Yeah.
Then a serrated knife is usually used when the tissue is very tough and fibrotic.
Okay. Achint, I want to ask you one question. What are the advantages of single stem over double stem?
Sir, single stem, there is less current scattering, and it gives stability to the loop. And double stem, it has two proximal openings in which we have to uh, insert the loop, so it can be easily dislodged, and it could lead to current scattering, more chances of current scattering also.
What else?
this many and
First of all, understand in the single stem, as you said, stability. Why? Because there is a support system in a single stem. Second thing is, single stem is easier to insert into the instrument because it is only one stem. So the chances of damage to the loop at the entry point is very less. If it is double stem, okay, when you are inserting it, it will wobble and it may not enter into the hole
yes,
where it has to go. So the chances of it getting damaged are very high. Third thing is the current. Okay. So here in the double stem, you have to apply the wire from behind. So during that also you may damage the loop. Then that in the double loop, both the holes will become larger over the period. So there is too much of leakage of water during resection, and the less amount of water goes inside the system. So visibility may be affected. Then dispersion of the current. And the last thing is, when you are doing resection, there are chances that the loop may come out. It can dislodge very easily. Okay, so these are the disadvantages of double loop, and that is the reason nowadays everyone prefers, most of the people, they prefer single loop.
yes.
Dr. Gite, you want to ask any question on this? Pankaj bhai?
No, sir, I think we can move ahead.
We can go ahead. Okay, Swastik, next one.
Ajay sir.
This is a young male presented with scrotal pain. And, surgery being performed is varicocele surgery. Palamose operation is being performed. Then what are the various techniques of performing the surgery? Depending on the route of the surgery, it can be performed at suprainguinal, inguinal, subinguinal, scrotal route. And indications of the surgery, it could be a symptomatic varicocele, it could be painful chronic pain, chronic orchidia, and in cases of infertility, and in some cases occupational requirement, such as in military or police recruitment. Sir. Then, when will you do this surgery in the case of azoospermia? When other parameters are normal, such as normal FSH and LH, and normal testicular volume, and grade 2 or above varicocele. With this one.
And most importantly, female factor normal.
Female partner, yes.
Unless the female factor is normal, you will not do surgery for varicocele.
Yes.
So a young unmarried man coming to you with varicocele,
Yes.
a 15-year-old boy coming to you with varicocele, how will you manage that?
Sir, I would first like to ask what is the chief complaint? Whether it's a like clinical finding which we have found out incidentally, or he is mainly presenting with any orchidia, or
So it's an incidental finding that that boy has noticed.
so incidental finding. Will explain to the patient that we will that he has varicocele, and incidental finding. We have to reassure the patient, and if patient wants to get evaluated, we can get semen analysis.
You'll get a semen analysis done in a 15-year-old boy.
Yes. we will explain the eventualities of the varicocele which patient can have.
You should read management of varicocele in a adolescent or a young male. You see, the treatment decision is based not on semen analysis in these young kids. Here, the decision will be based on the testicular size. You will compare the testicular size on both sides, and if the difference is more than 10%, then that becomes an indication. Otherwise, you will keep this child on follow-up and keep a watch on the change in the testicular size.
Okay.
When the testicular size as well as also in the amount of varicocele the child is developing. But the most important thing is testicular. If the testicular size is going down, then it is the most important factor. So another thing I want to tell you, you said that indications. Now, one of the indication is latest is also when the patient has got impotency and the testosterone levels are going down. Because it has been proved now that varicocele can lead to decreased testosterone level. And another factor which is very important before doing varicocele surgery is that on examination, if there is a turgid, okay, epidermis, or if there is a beaded vase, or if you are finding any abnormality in vase, then there is no need to do varicocele surgery. Yeah. Pankaj bhai, anything else?
No, sir.
Okay. Swastik, next one. Dr. Gite is not there.
I don't know. I have not checked. Maybe I just checked.
Was there, but presently
No,
sir. Left, sir. Gite sir left.
I think he was traveling. That's what he told me. He had come to Mumbai and he was traveling back. Okay, anyway. Achin, answer.
So this is the procedure is retrograde urethography, sir. Name procedure. Enumerate the findings. It all the bony architecture appears normal, and there is stricture at the bulbomembranous junction, sir, and there is calcified vas, sir. And
What
coming to
else?
the steps of the procedure.
What about, can you see something at pinoscrotal junction, means that is penile urethra and bulbous urethra?
It's
There
just
must be some
abrupt,
stenosis
almost,
over there.
sir.
See, little in distal urethra, distal to the bulbous, at the junction, pinobulbous junction, there is a, in both the films, you can see it is not straight. So there must be some stenosis over there.
Distal bulbous could be, sir.
Yeah.
But this could be normal. I don't know.
Okay, now discuss the steps of the procedure.
Steps, firstly, prerequisites of the procedure. There has to be a negative urine culture. Then position. First, patient should be the oblique position. First, there should be a scout film. Then oblique position with
Would
right
you
hip.
like to give some drug?
One alpha blocker can be given, but that's mainly for MCU, sir. In the night before.
Okay. Then
and only ideally in a film only one operator foramen should be visible, and the right femur should not be overlapping the anterior urethra picture, and right hip joint should be flexed. And steps of the procedure: we will hold the patient in the oblique position. We'll take a scout film. Then in our institute we hold the coronal part with the gauze piece, and with the Foley's adapter with a 20 cc syringe, we inject the dye, sir.
Dye or contrast? What you say in
Con-
exam?
Contrast, radio opaque contrast.
And what is the speed?
Speed, sir. So it's like 1 to 2 ml per second.
Yes. And how much you will inject? Or I mean, how many ml approximately before
Around,
taking?
around 10 to 15 ml, sir, at a time.
So what happens if you apply more pressure?
The dye could extravasate and it could lead to infection. If there is a stricture, we are suspecting a stricture, so it could extravasate dye also.
Okay. So enlist this thing, various contrast media that can be used.
Could be, sir. In our institute, we use Guliographin 76%, which is sodium ditriazolate, and depending which contrast media, ionic, non-ionic, high osmolar, isoosmolar. So all these can be used. It has to be radio opaque. That's the prerequisite.
Hiren, Dr. Hiren, you want to ask any question? Dr. Anil Huddedar is there. Please unmute, make him a co-host.
So I want to make few small comments. One,
Yeah,
don't
please.
use I always say contrast. Don't say inject, say instill.
Instill, yeah,
Yes, we are not injecting, we are instilling. So
correct.
the way you would say is that you would stretch the penis and very gradually at low pressure instill contrast in the urethra. You may say 1 to 2 ml per minute per second. Okay. And you will instill till either you get resistance to this installation or means there is some leak by the side of your Foley adapter. That would be a sign. If there is a stricture, the contrast will not go in, and there will be a resistance to your contrast.
Yeah.
Okay.
So these are the very.
Before you explain any procedure, when if you are asked to explain any procedure, the first thing you should say is that I will explain the procedure to the patient. So something like a consent would be very, very important in this. So I'll explain to the procedure to the patient, take consent with all aseptic precautions, give the position, stretch the penis, instill contrast at a low pressure and a gradual installation.
Also, sir, urethra is one organ that is dispensable. So when they are saying, they should use this word dispensable.
Yeah. And one more question I want to ask. What about xylocaine jelly?
Xylocaine jelly could be applied little bit only just previous to the insertion of the Foley's adapter. Otherwise, it may give falsified finding.
So only to avoid the discomfort at the meatus,
Yes.
basically. Otherwise, because that jelly, what are the disadvantages of instilling jelly into the urethra before this procedure?
It will give, sir, false results because the jelly will occupy the entire urethra.
Okay.
हेलो हाँ गौरंग
हाँ बोलो सर आप भी जो
हाँ
क्वेश्चन पूछना है प्लीज पूछ लो
हाँ नहीं ट्राई टू अवॉइड एयर बबल्स
फाइन
हाँ ट्राई टू अवॉइड एयर बबल्स इन दिस वन इंजेक्टिंग इंस्टॉलेशन ऑफ द डाई
Yes.
during the contrast installation always remember okay
Yes,
air
sir.
bubble should not be instilled inside fine so any other question otherwise we'll go ahead to the last one Swastik last one
What is the sonourethrogram?
yeah what is sonourethrogram
Sonogram means ultrasonic evaluation of the urethra, sir.
Mm-hmm.
So how it is done?
Sonogram, it used
Like
to
it is
assess the
any of the simple ultrasonography you do of like a scrotum or you do corpora.
It should be a 7 to 12 hertz probe, sir. It a high frequency probe. It is used to assess the spongiofibrosis prior if we want to use for structure for management.
But you want
How
to
do
see
you
the
compare-
urethra properly.
Yes, sir.
You instill some media.
Media, so I have no idea, sir.
Pankaj bhai, can you just throw some light on that?
So how does it compare to a standard retrograde urethrogram?
Retrograde urethrogram, sir, is a X-ray study, sir.
So how does it compare? Means if suppose I give you means what I mean is what are the advantage of sonourethrogram over a retrograde urethrogram?
So retrourethrogram will just identify the length of the structure and the site of the structure. Sonourethrogram helps us in identification of the amount of spongiofibrosis surrounding the structure, and it helps in the management aspect also, sir. As we can decide, we need to use any flap or graft for that place, depending on thickness of the spongiofibrosis.
Good. So in addition, you get information about spongiofibrosis.
Spongiofibrosis, yes.
Good.
Many a times in the this thing you may not get the length in the RGU because the dye may not, the proximal part you may not be able to identify properly. That you can do only by MCU and means both the studies. So that also will be little helpful.
Yes.
Fine. Okay. The last one. Achin.
Yes, sir. This is double J stent, sir. And various types of it are, it could be a single coil, or it could be a double coil, or depending on the material used, it could be polyurethane, silicone, or metallic stent. Coming to complications, complications.
1 minute, 1 minute. What about other things? You said single coil, double coil, multiple coil, open end, close end,
Open
then
close in the urethra,
sizes.
depending on size, sir, it varies from.
No, it is here also. Earlier we used to get. You can directly put the hard part of the guide wire or the glide wire. Okay, make it straight like a uretic catheter and put it inside.
I haven't seen that first. And
Earlier we used to get.
it could
Now
be
we are always
double
putting it on a guide wire.
yes.
Then the different sizes. So which are the sizes available?
Sizes are start from, sir, 4 French up till 7 French, sir.
3 French is also available. 3
French.
French.
3 French.
3 French. Okay.
3 to 7. And apart from that,
Length, sir, starts from 16 centimeter up till
26.
26, 28 centimeter.
and what about endopilotomy stent?
Yes, sir, they are a specific endopilotomy stent with difference in the French of the proximal end.
So what will be, how you explained it, what is the size available? If I say it is 6 by 12, what does that mean? Or 7 by 14? The tip is 6 French and the belly is 12 French. the maximum diameter. The same way 7 by 14. Understood?
Yes, sir.
So these are then okay.
Regarding the sizes, Achin, there is a collaborative chart where you can see what size for what height of the patient. That you should know. I have forgotten what the values are, but there is a chart that you can refer to. In which patient to use the 22, 24, 26, 28, up to 28 centimeter is available stent.
Yes.
I think Pankaj sir must be remembering in RG we had a chart where we used to see according to height and then put the stent.
Yes, I think it was 20 centimeters for 5 feet 2 inches, and then 1 centimeter for every inch that the height goes up. So this was very, very approximate. But what are the other ways of deciding the length of the stent?
Correct.
Can measure the length from the Ziphy sternum to the pubic symphysis.
So उससे कैसे पता चलेगा?
So that is the approximate length of the
Sternum to pubic symphysis.
Ziphy sternum.
Okay. ऐसा कहीं पढ़ा है आपने?
What has it? I cannot quote anything.
I don't think मैंने ऐसा कहीं पढ़ा है, but okay, if you have read, I'll accept that. Anything else?
Nothing.
The simplest is when you put a ureteric catheter, there are markings on the ureteric catheter.
Well, yes, well, that's an invasive measure. Yes, we can do it.
So when you're putting in a stent,
Yes, sir.
yes, you can also calculate it over a CT scan. Okay, and then
So intraoperatively, one more method. One was this the ureteric catheter you said. Second, sir, when we are doing RIRS, also we see many times that if the ureteroscope is not gone fully, like you have reached the pelvis, but the ureteroscope has remained outside a little bit, then normally a 24 French would be. But if the ureteroscope has gone completely and we are up to the pelvis, then about 26 French. So that's how we also decide about the access sheet, 35 or 45.
True.
So that is one
Earlier,
more way.
na, Pankaj, earlier we didn't have CT scan. So that time we used to do X-ray or like, IVP. So
Right.
that was a real image. It was not like now, compressed or
Digital image. Yes, yes.
yeah. So that time we used to actually take the ruler and measure what is the length of the ureter.
Absolutely.
So these are all the ways, Achint, you must know about this. Okay.
Yes, sir.
Try to find out about that chart. Maybe it's there in one of the some journals or
Yes.
it's not there in the Campbell, but somewhere we had found it. I just try to find out. Maybe endourology, Smith's endourology.
Yes, I'll find out.
Or anyone, any student, if they find out, please put it on the group. Okay. Name the complications associated with its use.
It could be stent
So this is during insertion, huh?
during insertion, sir.
So start during insertion and then later.
Intraoperatively, we can actually, it might not be in the urinary system, it could be outside the system, that eventually post-operatively will lead to uridoma formation. And stent immediately post-operative, it could migrate down. And
No,
sometimes,
migrate up first. You may insert it more inside, no? So it may go up into the ureter.
yeah, intraoperatively, by mistake, you can insert
Yeah.
into the ureter itself. The lower end is not quite. And post-operatively, sometimes it comes out in the bladder.
So can it perforate the ureter during insertion?
If we have done a stone lithotripsy with a inflamed ureter, it could haven't seen any perforation.
Then if there are multiple stones, fragments, it will be difficult to put it inside. It may not go also.
Yes, sir. If the lumen is so
Then-
much compromised, it doesn't pass.
Then it may raise the mucosal flap, and then it is maybe very difficult to push digestion inside.
Yes.
And Can it go and insert? Means, can you the tip can go into the parenchyma if you overzealously if you put the stent?
Yes, sir.
Can it go outside the system from the kidney?
Yes, sir. It might perforate the pieces or the
Pelvic
uterus.
calyceal system. Can it
Yes.
cause bleeding?
Yes, sir. It can cause bleeding also.
Then post-operatively?
Post-operatively, immediate post, it could be stent colic or
Hmm.
stent colic, sir. And
Again, bleeding. It can cause bleeding. It can lead to infection. Then the
Stent,
migration.
stent
Or
dysuria.
this, yeah, or the stent may come out.
yes, sir.
Expulsion of the stent.
Yes.
Then forgotten stent.
The delayed post-operative could be encrusted stent, forgotten stent, broken digestion.
So in the various type of stent also you have to mention about long lasting means for like for the 6 months or 1 year or the short duration stent. So last question, how will you manage the bladder spasm and pain which occurs due to stenting?
It could be managed by alpha blockers, anti-muscarinic agents, and beta-3 agonists.
Okay, fine. Any other questions? Maheshwari ji? Pankaj bhai?
हाँ जी सुनो सब।
Okay. I think we have finished quite a lot, and whatever extra is left, I will put it on the group. If you
Yeah.
also have any suggestions about OSCE, please, because this OSCE is not only for the OSCE, it can also help you in vivas and on tables and spots. So whatever extra thing you want to know, please put it on a group. So we'll discuss it next time. Okay,
Yes.
fine. Any other questions? Any student you want to ask any question? Fine. No other questions. Okay. Good night, everybody.
Good night, sir.
Good night, Pankaj sir, Gaurang sir,
Pankaj bhai,
Goldeo sir.
thank you very much.
Good night, sir. Thank you. Bye.
Yes.